Last time I talked about duodenal ulcer, I purposely deferred talking about gastric ulcer. But one mistake I made was I did not talk about H. pylori eradication. I don't know whether it's because it was never a part of yesteryear's management or because age is calling on my memory. H. pylori eradication has become very important. Last time when we talked about gastroscopy or duodenoscopy, indications for gastroscopy, duodenoscopy, one group I mentioned was recurrence of symptoms, slow response to symptoms, and patient who were compliant in treatment. The deep penetrating chronic ulcers have disappeared, and therefore elective surgery has also gone. But such patients who repeatedly come with relapse have slow response treatment. Gastroduodenoscopy is a must, and here the testing for H. pylori becomes a must. There are several tests used: radioactive carbon, breath test, CLO test, laser test, and the best is, of course, gastric enteromucosa demonstrating the H. pylori. Once the H. pylori has been demonstrated, eradication, in addition to H2 blockers or proton pump inhibitors, eradication of H. pylori becomes extremely important. The combinations used in management of eradication of H. pylori is clarithromycin and amoxicillin, clarithromycin and metronidazole, clarithromycin and tiniodazole, amoxicillin and metronidazole. It usually courses for 10 to 15 days. The kits are available, ready-made kits are available. If a disease does not respond to it, but it happens very, very rarely, less than 5% cases, you have a salvage therapy which consists of bismuth subsalicylate and amoxicillin, or amoxicillin and levofloxacin. The cure rate is almost 100%. Let's come down to, sorry for having forgotten this last time. I shouldn't have, but I made a mistake. I'm extremely sorry about it. Let's talk of gastric ulcer. Many years ago, gastric ulcers were discussed differently. They tried to show it as different diseases. But over the years, after the advent of gastroscopy and H2 blockers and proton pump inhibitors, we have come to a conclusion: gastric ulcer is an acid peptic disease. The only problem is it's not associated with hyperacidity as duodenal ulcer. There is no evidence to suggest that there is an increased parietal cell mass. It's supposed to be a disease more of a failure of mucosal defense rather than hyperacidity. Gastric ulcer is an acid peptic disease. Another controversy which was there when I was a teacher, and I teach in medical college, the benign gastric ulcer. When we use duodenal ulcer, we don't use any prefix suffix. But in gastric ulcer, we use a prefix called as benign gastric ulcer. We don't call it peptic gastric ulcer, we call it benign gastric ulcer. The reason is there is a malignant counterpart. There was a controversy whether benign gastric ulcer given time changes into malignancy or not. I used to teach 30 years ago, about 4% gastric ulcer turned into malignancy. Then later on, percentage came down to less than 1%. Today's contention is benign gastric ulcers do not convert into malignancy. They are missed or malignant ulcers are missed for benign gastric ulcers, because sometimes malignant gastric ulcer acted upon by acid peptic digestion tend to make an appearance of benign gastric ulcer. Therefore, this reality always must be kept in mind as and when you are talking about gastric ulcer. When we come to why is it that benign gastric ulcer was differentiated from duodenal ulcer? Number one is the age is more advanced. It is a disease of 20 years older than the age group of duodenal ulcer is shifting up. The age group of gastric ulcer is also shifting. They're almost beyond 60 years. It's a disease, male and female ratio in duodenal ulcer is 3 to 4 males to 1 female. Here the ratio is practically equal. Duodenal ulcer was a disease of upper socioeconomic strata. The gastric ulcer is a disease of lower socioeconomic strata. It is more closely related to smoking, alcohol, tobacco chewing. Comorbid, associated comorbidity is a higher incidence. People who take aspirin, NSAIDs, anticoagulants, painkillers is higher in gastric ulcer as compared to duodenal ulcer. The complication rate in gastric ulcer is more. The chance that malignant ulcer could be missed for a benign gastric ulcer is very real. And therefore, benign gastric ulcer is slightly different from duodenal ulcer. When we talk of the ulcers which occur in stomach, they were classified by Johnson into type 1, 2, and 3. Type 1 was a classical benign gastric ulcer situated at incisura angularis on lesser curvature. This type 2 was a slightly higher ulcer on the lesser curvature and associated either active or healed duodenal ulcer. And type 3 was a prepyloric ulcer. Type 4 was ulcer situated anywhere else, higher up in the gastroesophageal junction or anywhere in the stomach. This classification was probably meant because the type 2 ulcers, which occur in the middle of lesser curvature and associated with duodenal ulcer and prepyloric ulcer, had a higher acid output as compared to a classical gastric ulcer, which was situated at incisura angularis. As I said, gastric ulcer is more of a disease of a mucosal safety rather than a disease of acidity. Therefore, acid studies are never done. The presentation of patient is an elderly man or a woman, presents with dyspepsia for a long time. Pain is in the epigastric region, it is dull aching. The classical description is the pain increases after meals and subsides after few hours of meals, opposite to duodenal ulcer where the pain appears on empty stomach and disappears after the food passes. Such classical histories are very rarely available. Most of them have vague upper abdominal pain and vague upper abdominal symptoms. The only sign is tenderness in the epigastric region. There are no clinical signs to make a diagnosis of gastric ulcer. Therefore, gastric ulcer is a presumptive diagnosis till you recommend a gastroduodenoscopy. And gastroduodenoscopy in a man who is older, a man who has lost weight, man who has dyspepsia for a long time, man who does not respond to your H2 blockers and proton inhibitors which are given like kharas to the patient. Such a patient must undergo gastroduodenoscopy. The gastroduodenoscopy shows a classical chronic ulcer, exactly like a duodenal ulcer, about a centimeter in diameter, rarely more than 3 centimeters in diameter, has sloping edges, has slough on its surface, has a granulation tissue, penetrations beyond stomach wall is rare. Apart from seeing a gastric ulcer, another thing which is absolutely essential is taking biopsy. When we were teaching, we used to say, take 4 quadrant biopsies at 4 places. Today, the recommendation is take minimum 10 biopsies. Biopsy is absolute must. And enteral mucosal biopsy. Associated Helicobacter pylori, presence or abscess must be ruled out. Therefore, the sheet anchor in the diagnosis of gastric ulcer is gastroduodenoscopy, and you wait for histological report. You will start a treatment, but you wait for histological report whether it's benign or malignant. When you are suspecting malignancy for some reason, either because of its size, because it is placed at an unusual place, because there is suggestion of an eversion of age at some place, in such situations, demonstration of healing after therapy proton inhibitors or H2 blockers is absolutely essential. These patients are put on classically as as a duodenal ulcer on proton pump inhibitors as well as eradication of H. pylori, and suspicion of benignity on any count, either histological or on naked eye examination on gastroscopy, demonstration of healing is absolutely essential. Partially healed ulcer, slightly healed ulcer are no arguments to exclude malignancy. This is very important. The reason is when a gastric ulcer is missed, malignant ulcer is missed for a benign gastric ulcer, is an early presentation of malignancy. One vies for early diagnosis of malignancy, and this is one situation where early diagnosis is possible. Therefore, one must be very, very cautious in dealing with a gastric ulcer where there is a suspicion of malignancy. Treatment is exactly like duodenal ulcer. The treatment is by H2 blockers and proton pump inhibitor for a pretty longer period, sometimes needed for 3 months. These patients respond well. The non-compliant patient usually comes back with symptoms. Sometimes gastroscopy demonstrates healed ulcer, and even then dyspeptic symptoms persist. Here you should either investigate a patient for some other cause, or it's a psychological abdominal pain. Then we come to, after gastric and duodenal ulcer, we come to complications. As I said, routine surgery, surgery for elective surgery for duodenal gastric ulcer has practically disappeared. All of them heal on medical treatment. Very rarely you have to intervene. But the intervention comes when they undergo complications. Both the ulcers are, 3 important complications are: number 1 is perforation, number 2 is bleeding, and number 3 is stenosis. Let's first talk about perforation. Duodenal ulcers perforate, anterior wall ulcers perforate. Posterior wall ulcers, because they have a bed of pancreas, usually don't perforate. Gastric ulcers perforate wherever they are. The perforation is by and large, clinically, patient presents with acute abdominal pain in the epigastric region, usually without vomiting. These patients usually belong to a group of more than 50. In duodenal ulcer perforation, males predominant. In gastric ulcer perforations, there is no preponderance of male or female. The patient develops general signs and local signs of peritonitis. Discussion on peritonitis and its classical presentation is beyond the scope of this lecture. Therefore, I am not going to go, because they have a chapter by themselves. But one word of caution, apart from general signs, the general signs do come. They come as based on size of perforation, whether the patient had taken food prior to perforation, what duration does he present after perforation. General signs are of shock and electrolyte imbalance, dehydration. Local signs is tenderness, guarding, rigidity, free fluid, onset of peritonism and a paralytic eyelids. In an older person who is on NSAIDs, aspirins, painkillers, and age, of course, beyond 70, the local signs are a bit masked. Therefore, one should be very careful in making a diagnosis. The suspicion is always there, and a few more conditions are likely to be missed, especially if patient does not give a prolonged history of dyspepsia for a long time, or history of being on intermittent proton pump inhibitors or H2 blockers. In such patients, differential diagnosis comes of acute upper abdominal pain, acute cholecystitis, acute pancreatitis, acute mesenteric infarction. And therefore, in this patient, routinely serum amylase is done. The diagnosis is established by taking an X-ray in upright position. Unless the patient was in severe shock, it is always possible to take an X-ray, either in sitting position or in upright position. Let gas first ascend to the diaphragm. Wait for a few minutes before you shoot. And it takes minimum 6 hours for gas to appear in the diaphragm, usually in the right dome diaphragm. But in 12 to 18 hours, almost 80% patients show gas in the diaphragm. And therefore, it's one of the very diagnostic signs. Sometimes a CT is done, especially if the gas was not seen at the diaphragm. The CT demonstrates free gas in the parietal cavity. CT demonstrates excludes the differential diagnosis of acute cholecystitis and pancreatitis. CT scan is not a routine investigation for diagnosis of perforation. Treatment is, of course, general first. Settling a patient, putting an IV line, putting a Ryle's tube in, emptying the stomach, adding antibiotics, correcting electrolyte imbalance, may take few hours, but don't take a long time so that patient deteriorates. Because the most important prognostic factor in both the ulcers perforation is the time when perforation occurs and your knife, putting your knife on the abdomen. Duration is very, very important. Therefore, don't take too long to correct the imbalance patient has. The treatment is surgical. Medical treatment, conservative treatment, but a full-fledged perforation is discarded. Only when an ulcer is a small leak which lasts for a few hours, and by the time patient comes to you, he already has a settled upper abdominal peritonitis with well-settled, stable general size, that a conservative treatment is tried, and this is less than 1% cases. Most of the patients are operated. You can operate either by open surgery or by laparoscopy. But more is a contamination. The rule is the perforation should be sutured and peritoneum must be lavaged. For a nice peritoneal lavage, you need a larger incision. Therefore, most of the perforations are opened, especially if the duration is more than 12 to 18 hours. If duration is less than 12 hours, patient's general condition is stable, there is not much of soiling of parietal cavity, the perforations have been closed laparoscopically with marginal lavage of the patient. But the better treatment is patients with us tend to present late, they are elderly, they have a lot of contamination of parietal cavity. Therefore, open method is preferred over laparoscopic method. The principle is close the perforation. In duodenum, we use our mental patch additional to close it. We come out. Elective operation or operations meant for reduction of acidity are not done these days. It was in the past, they used to combine these operations in early perforation with stable general condition of patient. One needs to know that now that you have agents which reduce acidity markedly and practically 100% ulcers heal because of therapy, there is no need to add additional operation in emergency and increase morbidity and mortality of patient. Therefore, elective surgery in perforation has gone out of date. Gastric ulcer is also closed, but it is absolutely imperative that you take a biopsy from an ulcer. Sometimes the ulcer is small, you can excise the whole ulcer and then resuture the stomach. You get a nice material for biopsy. One never forgets to take a biopsy in gastric perforation. Prognostically, gastric ulcer perforation are much worse as compared to duodenal perforation. Not only because of age and associated comorbidity, but the size of the perforation, leakage in repetitive, the pilferage is more. Gastric perforation has a higher mortality as compared to duodenal ulcer. Fortunately, the incidence of these perforations has gone down because patients eat, I call it eat, the H2 blockers and proton pump inhibitors as and when they have upper abdominal pain. The medicines are available without prescription. They are very safe medicines. You can buy it any time. And therefore, perforations, chronicity, penetration have become unusual. But as and when perforations occur, the prognosis has gone down because they tend to present at elderly age, because they tend to present with the patients who have comorbidities. The second complication of peptic ulcer is bleeding. It either presents with hematomasis or melena. There is no method to diagnose hematomasis and malignancy. They are very obvious. The patient has large quantities of brown colored stools, or he vomits fresh altered blood. Small bleedings are common. All bleeding patients need hospitalization. Or the causes of upper GI bleed, a patient who gives history of duodenal ulcer, gastric ulcer in the past, patient who gives history of being treated for duodenal ulcer and peptic ulcer in the past, the diagnosis of duodenal ulcer comes to your mind first. But it is no more number one cause of bleeding. The number one cause of bleeding has become portal hypertension, erosive gastritis, causes coagulopathies. Most of these patients who are more than 60 are on anticoagulants. Therefore, one should be very careful in making etiology diagnosis of hemodialysis. They say you start a general therapy, putting in a rice tube, clearing the stomach, giving the stomach wash, putting a patient on IV proton pump inhibitor, establishing a IV line, getting blood cross-matched, starting an IV fluids, putting a patient on antibiotic, but specific therapy for a bleeding should never be started unless diagnosis is confirmed. And the diagnosis is confirmed by, again, gastroduodenoscopy as early as possible. Better earlier than late. Very, very few patients bleed so horribly that gastroduodenoscopy becomes difficult. But they say the expert people are willing and do gastroscopies in such patients also. By and large, when you start a basic therapy, most of the bleeding stop. 80% bleeding stop because the source of bleeding was possibly the granulation tissue erosions around the ulcer. You have a time to do a gastroscopy. If rebleeding occurs, or if the bleeding is massive, the gastroscopy reveals the site of bleeding. That's very important. That's very important for a surgeon to know what exactly is bleeding, where is the site of bleeding. Therefore, gastroduodenoscopy becomes an absolutely essential investigation before you intervene. Most of the patients stop bleeding. You confirm the diagnosis that it was a duodenal gastric ulcer, put a patient on proton pump inhibitors and eliminate Helicobacter pylori. I think the chance of rebleeding is there, but most of the patients respond to this treatment. Rebleedings or massive bleedings need further treatment. Further treatment is gastroscopic, embolization, and surgery. There are three methods to stop bleeding from duodenal ulcer or gastric ulcer. The first one is gastroscopic. They use gastroscopic heater probe, they use local adrenaline, they use local sclerosants, they use a clip to occlude the bleeding vessel, and in more than less than 10% patients go for this treatment, but more than 90% patients respond to this treatment. The bleeding stops. If this does not help, there is another method, embolization. Where a facility of interventional radiology is available, they go for embolization. As we talked in anatomy, because stomach is so vascular, you usually need more than two vessels to be. Injection of a dye tells you what is a vessel which is supplying the bleeder. Usually, left gastric artery pedicle, right gastric artery pedicle is one main branch in benign gastric ulcer, and Gastroduodenal vessel or its major branch in duodenal ulcer is responsible for such possibility. If this does not respond to clipping, they're treated by embolization. And you need to embolize more than 2 vessels. And radiology could demonstrate that the bleeding has stopped, then only your embolization is complete. If the facility of embolization was not available, or if embolization does not stop the bleeding, the treatment is open surgery. By and large, open surgery, laparoscopy. For duodenal ulcer, open this once you know that there is a duodenal ulcer which is bleeding, you do a gastroduodenotomy. Open the pylorus and the lower part of stomach. You mobilize the duodenum, second part of duodenum, so that the bleeding duodenum is in your hands. The ulcer is underrun by sutures, usually absorbable sutures which are absorbed for a long time. The suturing must be perfect. The bleeding should stop completely. And the pylorodionectomy either is closed straight or you do a pyloroplasty. Nobody adds, again, ulcer reducing operations in emergency. You know, a very serious patient has gone for laparotomy. He has already bled. He's already in shock or has come out of shock. In such a patient, to add additional trauma of acid reducing operation has gone out of fashion. And very true. Once the bleeding is stopped, you put a patient on POTAP inhibitors and H. pylori eradication. Usually, it's a successful treatment. For gastric ulcer, if the ulcer excision and suturing stops the bleeding, well and good. You need a nice wide gastrotomy, insert the anterior wall of stomach, expose the ulcer, find out what is bleeding. You can try to ligate the bleeder or suture the bleeding. If that doesn't help, you can excise the ulcer and suture the stomach, very deep sutures in the stomach. If this does not help, if it is not possible, you do a partial gastrectomy. There is a very, very thin chance that once in a while, a bleeding which is not controlled by suturing the ulcer or by excising the ulcer or by taking deep sutures, that you excise the stomach below the gastric ulcer and do a partial gastrectomy. Usually anastomosis is reestablished, continuity is reestablished by gastrojejunostomy. And such ulcer must be sent for histology. The malignancy must be excluded. Mortality is very high. It's needless to say, the patient was old, patient had comorbidities, patient was an anticoagulant, has gone through a very rough treatment of prolonged duration preoperatively, and then you put a patient on operation. That mortality is high, is no doubt about it. The third complication is pylorostenosis. In duodenal ulcer, pylorostenosis is a misnomer. What undergoes stenosis is duodenum, not pylorus. Pre-pyloric gastric ulcers can also produce pylorostenosis. But today, healed duodenal ulcer or healed pre-pyloric ulcer producing a pylorostenosis is much less common as compared to malignant pylorostenosis. Today's pylorostenosis is more commonly because of malignancy of stomach situated on the lesser curvature and pre-pyloric region rather than benign pylorostenosis. Many times patient gives history of long-standing H2 blocker and H2 and proton pump inhibitor therapy. Sometimes it was so long ago that patient completely forgets about it. But this pylorostenosis is of a long standing. Presents classically, we talked about hyperostic pylorostenosis, we talked about pylorostenosis, visual peristalsis, vomiting 4-5 hours after meals, the undigested food comes out, the vomit never contains bile. With such classical history, patient losing weight, was on treatment for a peptic ulcer for a long time, and has a visible peristalsis of a stomach, the clinical diagnosis becomes very easy. Once in a while, you do a gastroscopy to demonstrate a narrowed pylorus. In age-old times, barium meal was a very useful investigation. 2 mouthfuls of barium given to a patient used to go down and sit in the dilated stomach and used to be seen as a trans shadow in the pelvis. It was called a soup plate stomach. A very classic, unfortunately very, very rare now. Once the diagnosis is established, the way must be created through the pylorus. You have 2 conservative methods. One is dilatation by balloon. Gastroscopic dilatation of balloon. This therapy has a disadvantage of recurrence. You have to do it many times. Sometimes the narrowing is so fine that you can't put a balloon. People have tried to put a stent when recurrence is after balloon dilatation. Stents get displaced. And a patient should afford repeated dilatations or repeated putting stents. If this is not possible, the best treatment is gastrojejunostomy. Bypass the obstruction by anastomosing the stomach to the jejunum, first loop of jejunum, by electrocolic gastrojejunostomy. Wonderful. Here also you don't add acid reducing procedures, not only because patient is usually old and the ulcer has healed, has been present for many, many years ago, and you have, if there is a chance of recurrence of hyperacidity, you have protoporphyrin inhibitors and H2 blockers in your hand. That completes peptic ulcer completely. We'll go on to carcinoma stomach next time. Thank you.